So we're right at 9. I think we will get started with a bit of the formalities. Welcome everybody to the spring education session of the CKD Clinic Network. For those of you that don't know me, I'm Monica Bollier. I'm a nephrologist at St. Paul's Hospital, and I'm happy to chair this today. I work in what is right now a sunny spring day on the traditional unceded and ancestral territories of the Musqueam, the Squamish, and the Tsleil-Waututh. And today it's my pleasure to welcome Marissa Battistella, who is, I think many of you know, she is a clinical pharmacist extraordinaire at the UHN in Toronto, who has a long history in nephrology care. She's also the associate professor at Leslie Dan Faculty of Pharmacy at the U of T and a clinician scientist in pharmacy, and really has built a career and a focus on research in pharmaconephrology. Today, she's talking about a topic very near and dear to my heart. It's really ensuring that the medications we are advising our patients to take are the right ones for them. And as I go through a bit more of this work, to me, it's really like mindfulness for medications. It's being mindful of medication delivery for our patients. And so Marissa, thank you for coming today to talk to the CKD Clinic Network about managing polypharmacy in our CKD patients. Over to you.
Great. Thanks very much. Thanks for inviting me to speak today. Please let me know if I'm not loud enough. So today I'm going to talk about managing polypharmacy and the role of deprescribing in patients with chronic kidney disease. These are my disclosures for today. And so I have three main learning objectives, and that's to describe the potential harms of polypharmacy in patients with CKD. We'll identify medications with poor evidence for efficacy, as well as safety in CKD. And hopefully we can apply some tools and approaches to medication deprescribing in the CKD population. So I have a few questions. I don't expect you to answer them right this minute, but I will come back to the answers throughout the talk. So it's just something for everyone to think about. So my first question, what is the average number of medications a dialysis patient takes daily? Is it 3 to 5, 6 to 10, 11 to 15, or greater than 15? So I'm going to start with a case of Mrs. P, an 84-year-old woman on hemodialysis for the past 6 months, secondary to diabetes. She's a widow living alone. She's had 3 falls this past year. Sometimes she gets confused and forgets things. And of course, her children are worried about her. This is her medications. She's on 20 different medications, which is quite typical of a hemodialysis patient. Most are packaged in a blister pack. So she's definitely experiencing polypharmacy. And so polypharmacy means really many drugs. Sometimes the literature describes it as 5 or more drugs. But I think more importantly, I think it means inappropriate choices of medications and inappropriate doses. So there's consequences to polypharmacy. First, on people, there could be decreased adherence to their medications, drug-drug interactions, and potentially adverse drug reactions. In fact, 68% report an adverse event after hospital discharge, and almost 3/4 of those are due to a medication. We can have consequences on our healthcare utilization. There's increased hospital admissions that were drug-related and potentially preventable. And of course, on cost, public drug programs spent $16 billion in 2021, and this is 15% of all healthcare spending. $10 billion is spent on just drugs for the elderly, and that's 62% of public drug programs, or 20% of healthcare spending. So there are risk factors for polypharmacy. Age, so the elderly, multiple comorbidities, acute hospitalizations, multiple healthcare visits, and multiple providers. So if we look at Mrs. P, she probably has multiple visits to the hospital, or at least providers. She's elderly, and she is on definitely many medications. So she's at risk for polypharmacy, which really want to introduce another concept of polypharmacy and why it can happen. It's called the prescribing cascade. So let's, for instance, a medication is added to a patient's regimen. If they have an adverse event from it, this is interpreted as a new disease, not really an adverse event from the medication. So a new medication is added onto their list to treat that new disease. And then they have another adverse event from that medication, and this is also interpreted as a new disease, so another medication is added, and so on. So this is called the prescribing cascade. So Mrs. P had a prescribing cascade. Her friends tell her to take some ginkgo because it helps with memory. And so she starts taking it. It's also known to increase blood pressure. So her family doctor decides to put her on some amlodipine. She gets pedal edema. They put her on some a diuretic, some furosemide. And at the same time, she's also put on lorazepam because she's not sleeping well because her husband had just passed away. So in combination, this can, lead to more urine output. She's still making urine. She's drowsy. And then she has urinary incontinence, so she's put on oxybutynin. So you can see how the prescribing cascade can happen if we're not mindful with the choices of medications and what's going on with the medications. So polypharmacy in CKD is common. This is old data, but in the US RDS in 1998 did a study. They showed that patients were on average of 9 medications a day. These are hemodialysis patients. They redid it 6 years later. They were now on 12 medications per day. We did a similar look at our dialysis unit in Toronto, and patients were on a median of 12 medications per day. So another question to think about, what's the most common medication used by dialysis patients? Is it proton pump inhibitors, benzodiazepines, statins, and opioids? And what's the most expensive drug used by our patients? Is it proton pump inhibitors, insulin, statins, or opioids? So we did a province-wide cross-sectional study looking at the demographics and medication use of patients in hemodialysis units across Ontario. And so we looked at we used 7 different databases, with the ODB being one of them. That's the Ontario Drug Benefit Formulary. And so that database collects medication information, and it's usually for patients greater than 65. But people on disability or social welfare would qualify to be covered by the ODB formulary. So we were able to use these 7 different databases, and we looked at demographics and medication use in 69 different hemodialysis facilities in Ontario. So what did we find? So the mean age was 76. They were on a median of dialysis vintage of 4.2 years. And they had the typical comorbidities of our dialysis patients: coronary artery disease, diabetes, heart failure, chronic lung disease. And they were on a mean of 11 medications per day. So just as a reminder, in Ontario, the Ontario Drug Benefit Formulary doesn't cover OTCs. So things like Replovite, calcium may not have been accounted for in some of our patients. Things like Aranesp is also provided by a special ministry, wouldn't get picked up in the ODB formulary, IVR, for instance, as well. So likely that number is slightly higher. So my first question to you earlier was what the average number of medications a patient takes, and that's probably somewhere between 11 and 15. We recently did a study, and as part of another study, and so it was 14. So I think it likely is somewhere around 14 medications per day. So primary care visits were common, mean 12, so that's 1 a month, or a median of 7. And they saw 3 different prescribers on average, and they were mainly a general practitioner, a nephrologist, or a cardiologist. What about the percentage of medication use in hemodialysis patients? So here I'm presenting mainly medications that we thought could potentially not be prescribed, may have the potential for adverse events. So we didn't have things like ACE inhibitors or ARBs, beta blockers. We could argue that maybe some patients don't need them, but this was not included in this part of the analysis. So here I'm showing statins were by far the most common, followed by PPIs, diuretics, opioids, benzodiazepines. So many patients are taking all these medications. What's the most common medication used by dialysis patients? I posed that question a bit earlier. It is statins, and PPIs and benzos and opioids are not far behind. The cost. So I'm showing here that insulin is by far the most expensive medication we use. Not far behind are proton pump inhibitors and things like calcitriol, statins, calcium channel blockers. So here I'm presenting just in general the medications that patients are on, even if we think they're appropriate or not appropriate. What is the most expensive drug used by dialysis patients? So it is insulin. So our study showed that polypharmacy is frequent in hemodialysis patients, and strategies to improve prescribing and increase deprescribing of ineffective medications warrant testing for better patient outcomes and reduced healthcare costs. So, which leads me to what deprescribing is. So this is the process of tapering, stopping, discontinuing, or withdrawing drugs with the goal of managing polypharmacy and improving outcomes. Why should we deprescribe in dialysis? Well, dialysis patients have a high pill burden. They're on a median of 12 medications per patient. Evidence for efficacy of many of these therapies is lacking in this population, and safety concerns for medications that are cleared by the kidney and not removed by dialysis. And so there are currently no tools for deprescribing, well, until recently, that are available for this population. So this is 10 years ago, but we did a pilot at our site at UHN. And so we looked at targeting deprescribing in our unit, and this was a quality improvement study to hopefully decrease polypharmacy. So there were 3 phases to our study. So the first phase was the development of a deprescribing tool. So we collected, we did focus groups, and then we looked in the literature at, common medications used, some of the adverse events, were they appropriate, was there good data on indication efficacy in this population. And we also used the data from this previous study I just showed you to get a sense of, well, which drugs could we potentially look at that may be really inappropriately used. So we chose 5 target medications, and this was based on risk of harm, little chance of drug withdrawal, unclear or no indication, but really unknown or minimal benefit, but there were always side effects or safety issues. So here are the 5 medications we chose: diuretics, PPIs, quinine. Yes, believe it or not, we were using quite a bit of that 10 years ago. Alpha blockers and statins. So diuretics, we only suggested to deprescribe for anuric patients, and we developed our algorithm for that, for anuric patients. Alpha blockers, not if patients were using it for blood pressure. Some patients do use it for blood pressure, and so it's really truly only for BPH. So if they weren't urinating anymore, they weren't having really any symptoms, then a discussion around deprescribing for alpha blockers. And then statins, this was only for primary prevention in patients greater than 80 years of age. So we developed our algorithms, and then we validated them. So we did face and content validity. We revised the tool and retested on an iterative basis for a total of 3 cycles. And we did this in consultation with 5 different nephrology team members. So we had 12 nephrologists, 2 pharmacists, and 1 practitioner. And our 5th phase was to implement it. So this was a prospective observational pilot study. We did this 10 years ago, started in May 2014. And so how we did this is that pharmacy would collect the best possible medication history. We would identify if they were on one of these target medications, apply the algorithm we had developed, inform the team, consent the patient, and then communicate the whole plan with the patient as per our algorithm. And when we did a follow-up 6 months later. So we had about 240 patients in the dialysis unit. 169 were excluded. 100 were taking it for a valid indication, and only 69 were not taking one of these 5 medications. We approached 71 patients. We excluded 36. I'll go to my exclusion table a little later. And so we recruited 35 patients and successfully deprescribed at the time, at the 1-month mark, in 27. And then at the end of 6 months, 19 patients stayed off their medications out of the 35. So we'll look a little closer at some of this data. The mean age was 65, sex 21 males, 14 females. They were on dialysis for a vintage of around 3 and a bit years, and they were on 13 medications on average. And they had the typical comorbidities of a dialysis patient here: hypertension, diabetes, cardiovascular disease. This is an example of what the PPI algorithm looked at. So you can say, what's the indication? And then we would go through the different reasons why someone would be on it. And if they were on it for unclear indication or GERD, we would assess their symptoms, patient summit, patient education, and decide, could we stop this medication? The back side of the algorithm had step-by-step of what to monitor, how to taper off the medication, etc. So we had 86 PPI users, 40 were flagged for inappropriate use. So we excluded 16 of those. 24 were enrolled in the study, and at the 6-month mark, 12 of them stayed off, which I think is pretty good. 50% stayed off their PPI. Of course, the most challenging part of the deprescribing process was really trying to figure out or collecting the data, why were they taking the PPI in the first place? And 27, almost a third of them had no idea or unknown reason why they were taking it. But these are the patients that we did try to stop the PPI in. So we monitored for a few weeks to see if they had any GERD symptoms return. 7 did represcribe after the first 2 weeks, and 1 patient died, not related to the PPI. After 6 months, 3 patients had restarted, and 1 patient had passed away. Just to note, we probably tapered too quick in this pilot, and so later on we've changed our algorithm that we taper a lot slower. So these were reasons why we excluded our patients. I want to point out that only 3 were anxious about stopping a medication. So only 3 patients did not want to consent to doing this. So I think that's really important because we want to, deliver patient-centered care, share decision-making. And so I thought this was really positive in the sense that we could move forward on a bigger scale with a similar type of project. So this is the overall results. I just want to point out, a lot of these patients were taking quite a few of these medications. If you look at statins, 95 patients were taking it, but only 1 really qualified for deprescribing, and we did deprescribe. So a lot of those patients were using a statin for secondary prevention, or they were younger and they were using it for long-term prevention. And that was what our algorithm stated. So we were successful in deprescribing in 77% of the cases. The average number of medications didn't really decrease, but patient safety and satisfaction increased, and that patients were open to deprescribing and felt that it was good that someone was re-looking at their medications. Of course, it has limitations. We had a small sample size, just our site. They could use their medications at home, and a new medication could be prescribed during the deprescribing trial. But I think we were able to validate 5 excellent algorithms for deprescribing. It helped guide clinical practice, especially for our trainees. And more importantly, I think it increased awareness of inappropriate medication use, or as I was introduced, medication mindfulness. So I think that was really, really important. So with the help from CanSolve Network and the Kidney Foundation of Canada, we received funding in order to implement our deprescribing program on a larger scale. So we had our deprescribing algorithms, the 5 in place. And so based on our pilot study, with these 5 algorithms, we added 4 more medications based on the demographic data that we had done earlier. And so the 4 new medications were prokinetic agents, gabapentinoids, allopurinol, and benzodiazepines. We created evidence tables for the clinicians to help with monitoring any of the symptoms that patients may experience. That was a monitoring. The evidence table was to explain how we came up with the algorithms. And then based on our pilot study, we had patient feedback that it would be good to have more or better education for the patients. And so we created a toolkit for the patients, which consisted of a video and a bulletin on each of these medications, and what to expect when deprescribing. So here is the algorithm for PPIs, 2 pages, with the first sort of very similar to our original one, going through reasons why they might be on it, reasons why you could stop. And then the second page really goes through how to monitor, how to taper, and what to use when you're tapering, such as like an H2 blocker. And this was the monitoring form. And this was designed to help clinicians really what to look for as we did taper a medication off. This was the evidence table. So this is just example, just 2 pages. It's a lot more pages, but it just goes through the different studies we use to help develop the algorithm. So we knew we needed to have buy-in from a national group, not just the clinicians at UHN. So we wanted to validate this, all our tools. And so we used the LIN method. And so the LIN method is a validation method that involves recruiting a minimum of 5 experts. If there are 5 or fewer experts, all of them must agree on this content validity for the rating to be considered a reasonable representation of the universal possible ratings. So what that meant is we used a Likert scale, and the algorithm was, divided up into different sections, A, B, C, D, E. And so they would rate each of those, on a scale of 1 to 5, what that section meant. And so they had to score between a 4 and a 5 for it to be valid. And so we did this 3 times. And so we had 15 clinicians review 3 algorithms, so 5 clinicians per set of algorithms. And then we would review their scores and their comments, and then we would revise. And we did this for a round of 3. So what did we find? So we interviewed 24 nephrologists, 17 renal pharmacists, and 4 nurse practitioners. And they had been practicing for a median of 15 years. So as you can see, we interviewed clinicians from right across Canada. So 45 clinicians were surveyed from Victoria all the way to Newfoundland. And so here's the results of the rounds. We actually needed 4 rounds for it to be content valid. And so what's showing here, for example, in red, is like for alpha-1 blockers, there were 6 components to the algorithm that we divided into, and 1 component didn't score high enough. So it took us 3 rounds, actually 3 rounds for us to have content validity. And some drugs, you can see, benzos, of course, it's controversial. Statins, also controversial, and urate lowering agents took us 4 rounds. For face validity, we ask questions like, is the tool clear and understandable? Does the tool use appropriate language and wording? Would you use this tool in practice? And so for the most part, the clinicians answered over 80% to these questions. So for the patient tools, we also use the LIN method, and we use 6 patients, so one could disagree. What's interesting is we also use the LIN method, and we interviewed 24 patients per round, so for a total of 72 patients. But for each set of 2 patients, 1 patient was interviewed by the research assistant at that site, either Winnipeg, Vancouver, or Toronto, and 1 was interviewed by one of our patient partners. So this is what the patient tool looked like. It was a 2-pager bulletin, as is the PPI one, and it does have the YouTube link right on it that would take you to the whiteboard video that also goes really through that same information that's on the bulletin. So again, we only had to do 3 rounds on this case. You can see the first round is where we had a little bit of discrepancy, but it just took us 2 or 3 rounds to come to full agreement on the content of the information. And then for the face validation component, we asked similar questions like, could you read the education sheet? Is it understandable for patients? Is the video clear? Do we use appropriate language? And for the most part, the patients scored a 4 out of 5 or 5 out of 5. I think interesting, there were 4 themes in total that came out from our 2 validation studies. So with the clinician tools, the clinicians thought communication between healthcare providers when prescribing is super important and the key to making this happen. And so we did do a Dear Doctor letter in our pilot, but that came out again that the other practitioners involved for other community pharmacies would have to know what was going on. And they thought a champion was needed. These are great tools, but I'm not sure how I'm going to do this. And so they recommended a champion like a pharmacist to help with the process. And then for patient tools, the patients thought both the bulletin and video were super helpful and needed both of them to help understand the material. And the patient tools provided patients with the necessary terms and concepts to help verbalize their thoughts or clarify opinions that they held, but they were unable to express. So where are we now? So we have started our implementation. This is our project line. We started implementation in Toronto. We've actually completed, so we'll have results to show soon, probably this summer. So we started that last year, and Halifax also started last fall, and they are almost coming to their 6-month completion. We have Victoria, BC on board, and they're hoping to start June-ish. And same with Alberta. They're just going through a few final details, and they're hoping to start later this spring as well, early summer. So this study, Stop Med HD, what we're trying to do is really look at the assess safety and effectiveness of our de-prescribing intervention in a 6-month period. And really we're looking at determining facilitators and barriers to implementing this practice at different sites so that it becomes part of practice. I have here our website, so feel free to take note, and all of our tools are handy on our website. You can go and feel free to use them and modify them to your best interest. So when we did implement, to guide our implementation, we use a conceptual framework in the form of what's called the de-prescribing rainbow. And this is initially reported by an Australian group, the Australian de-prescribing group, that just generally for their geriatric population. But it really outlines the clinical, psychological, social, financial, and physical determinants that should be considered along with these different algorithms and the patient when you're deciding to undertake a de-prescribing trial for medication with the patient. So what does that mean in practice? So how do we do this? So really the first step is to do a medication review and reconciliation. So you are going to review even their OTCs, herbals, complementary medicine, and reconcile any differences between what the patient's taking and maybe what they're supposed to be on, what's being prescribed. And then you'll assess the patient fully, their medical history and their goals along either with them, their family, their caregiver. And this is where we would also assess any social, psychological, financial reasons for why patients are taking the medication or not taking the medication. So we'll start with the case. I think it helps to sort of envision how to do this. So GB is a 74-year-old female on hemodialysis for the past 8 months, secondary to diabetes. Labs are all within normal range, excellent blood pressure and heart rate, and she's on a lot of medications. And so she asks, how can I optimize my medications? I'm taking too many of them. I think we all get this question all the time. So here you can see she's on not as many as my first case of Mrs. P, but she's on the typical medications that this patient would be on. So we would then evaluate the risk and benefit of each of the medications after we've reviewed and reconciled, and then we would identify potentially any inappropriate medication. So for instance, in her case, we might look at her furosemide and say, well, is she still making urine? Does she really still need this? Is 40 milligrams the appropriate dose? And so we would evaluate her de-prescribing eligibility using our algorithms and then prioritize medication de-prescribing. So here's back to her medication list. I have furosemide and lansoprazole in red because we have algorithms to help us de-prescribe. Not to say that the other ones shouldn't be reassessed and maybe de-prescribed. So oxybutynin is for urinary incontinence. Potentially she's not urinating anymore. So does she really need this medication? You can always reassess blood pressure pills, insulin dosing, and aspirin for primary prevention. So next we would communicate this with, first with the team, of course, but then our plan with the patient and the caregiver and any other health care team members. And we would implement the protocol by either tapering or just stopping a medication and looking for monitoring any potential side effects. We always assess someone's creatinine or potassium after we start an ACE inhibitor or an SGLT2 inhibitor. So same goes for when you de-prescribe, you should still be monitoring for things that potentially could come back. So my key take-home messages is decreasing medication use in CKD patients can reduce adverse events, reduce pill burden costs, increase adherence with their remaining medications, and improve quality of life. I think all team members have a role to play in successfully optimizing medication use in our patients, and taking the first step in developing a plan for a good medication review and strategic prescribing as well as de-prescribing are key to optimizing medications or being mindful of their medications in the CKD population. So I'd like to acknowledge all our co-investigators, students who have helped in the past, and of course our patient partners who've helped with some of the validation and implementation. So thank you, and I'm happy to take questions. Maybe I'll minimize my slides so I can see people.
Wonderful. And while you do that, just a huge thank you, Marissa, not just for presenting today, but for um, the body of work that you're researching and also the rigor and the methodology that you've put into doing this. I think a lot of us, implement a lot of changes, but the way the program has kind of grown over the last decade and what you've been able to show and some of the methodology, I think is wonderful. So
Thank you.
congratulations. And with that, I just wanted to open it up for questions and also to hear from non-dialysis CKD programs,
Yeah.
if any deprescribing has been, if there are any pockets around the country of deprescribing that we can help build on or have a discussion about.
Yeah,
So
yeah, and
question.
thank you, because I know my talk was more on our program in the dialysis population. That doesn't mean that we can't do this in CKD or other type of nephrology clinics. But so thank you for saying that.
So maybe if it's not hard, if we could just drop the slides and then we could see
Yeah, for
people.
sure. Oh,
A-
I'm not. I'm still sharing, aren't I?
Any questions from anyone on the call or comments?
Marissa, this is excellent. Thank you very much for as well how in depth and thorough your review of this is. It's a great tool for students to start out with when we're teaching them in the renal program too. So I'm going to definitely share that with some of our students. Thank you so much. Great to see you.
You too.
Is there anyone on the call who has any formal deprescribing in your CKD clinics, including those on a conservative pathway, or how do you approach um, this topic in your CKD clinics?
I might comment, like in CKD, we're often adding a lot of medications, as we know. A lot of medications do help slow the progression of CKD. But I think for other, if you're managing other symptoms, I think it's really important. Not, I'm not saying not to use some of the medications, because I think sometimes we do have to try as we run out of non-pharmacological agents to use, like pruritus and neuropathic pain. So I think it's always worth trying them. But I think the key, part of our deprescribing was really to come back and reassess, 4 weeks, 6 weeks, 8 weeks. If things aren't working, this is this is when we should stop them. We're always hesitant to do that. And I think, why not try? If, the symptoms come back, you can always easily get back on. So I think that's really, I think we learned a lot from this over the last decade. And I think that's, I think, an important message.
And I do think a lot of your algorithms would almost be similar to be able to be used in a CKD population.
Yeah. Maybe not furosemide since they're still
Maybe
making
not.
urine. But yeah, but I mean, at least it gives you, well, what if they're only on 40 and they're doing okay? You can always increase the dose. So I think it does, it does provide a bit of a framework for medication management in general. But yes, thank you. The other big question that comes up is like a failed transplant and we're still on prednisone and the PPI is still on board. And we talked about this at one of our journal clubs a few weeks ago, but they're on it because they're on, they get a transplant, they're on so many medications, they're on high doses of immunosuppression. And then, we do taper down the immunosuppression. And then often the prednisone is down to a very low dose, 5. So there's no other reason. So this is another one where we can try to, minimize how much PPI we're using. And, we went from we were able to stop in half the patients that we tried in. So it's better than not the other half. So I think, that's, some people might say, oh, it's only half, but I think that's really important. So.
Marissa, you also did some videos, patient-facing videos in general about deprescribing. Are those available on the website that you
They
put up?
are, yeah. And we actually, so that those are for each of the medications. And the patients like them because I think they get the piece of paper, the pamphlet, and it's super helpful, but then you forget. And I think having both, and that was their feedback, that having both was really helped them sort of integrate the information and process it. So that they are there. And we actually created a new video. It came out during World Kidney Week. But we interviewed patients in our dialysis unit in Toronto. We had 3 patients we interviewed. It's a 5-minute video, but you know, if you have patients that are concerned or not wanting to stop medications, you can show them this video, and they give examples. They weren't all in our study. One patient wasn't in the study, but she was very mindful and thoughtful about her medication use. And so feel free to, the videos there as well. Feel free to share that with your patients.
Judith.
Yeah, hi Marissa.
Hi.
Thank you for your talk, and thank you for all your enthusiasm on this throughout the years. I can't believe that it's been like 10 years that we're working on this. But you know, your comment about like, adding a lot of medication for CKD patient, you're right. And I think that actually adding the right medication at this point of time, when we actually have some therapy that can decrease the progression of kidney disease, is probably even more important. And so I think that it's very important for us to be mindful. And I mean, that's one of the things that actually I'm hoping to work on is the deprescribing part for these patients that feel very overwhelmed, but as well as they progress to conservative path, to actually put them on what are the right medication. And at that point of time, the right medication has changed to how it was at the beginning of their journey. So I think that that's as well for us. It's a good reminder that we need to follow up their journey, and what is appropriate at a certain point of time may not be at another point of time.
I agree 100%. Thank you, Judith.
Matt.
Thanks, Marissa. Really great work. Thanks for the presentations. Fantastic. And just also wanted to kind of reinforce, like, it's wonderful to have these algorithms and this process, and be able to other places be able to build on the work you've done and apply this and implement this in our setting and kind of lay out strategies for doing that. I was interested sort of more the practical experience you've gained from doing this, particularly like how many encounters does it take and how long does it really take, do you think, to do effectively? Does it tend to end up being one interaction, or do you kind of introduce this and then leave the patient with some material and you've got the handouts and the videos and then come back later? I just was interested in kind of your really practical experience, like of the best way working with patients to do this.
Right. So, so some of the cases I showed were, so when we did the study, it was a little bit more time consuming because we followed sort of a set rule and how we implemented. So we're really looking for information to help facilitate any of the barriers for centers to be able to roll this out in practice. So I don't have a time per se, but if you have a pharmacist in your dialysis unit or your CKD clinic, we are seeing patients. Like, that's part of our to review their medications. And so that's when this would really probably happen. It could be the nurse practitioner if it's a nurse-run clinic. They often review meds too. So sort of that champion of who's reviewing the medications. But that's part of the practice part. And then I think the other part is, when you do decide to stop. So I have all this like patient tool stuff for patients that are maybe hesitant, but some patients don't need it. They just, oh, I agree. Like, I've been wanting to come off some of these medications. Do I really need this one? So then it's just part of your normal interaction with these patients. So the tools are there to help the clinician as well as the patient. And you're not going to always use them. Sometimes we didn't use them and sometimes we did. And you'll know just from your relationship with that patient what they're saying to you. So I don't think it's adding, and that's the whole point of this, is hoping that it become part of your routine practice. So it really shouldn't add more time if you are reviewing medications. So yes, in some patients it will, but probably whatever you do in those types of patients, they will need longer time because they just need more time to think things through. And every patient is different in that respect. So, we know that as clinicians and we respect that. So I haven't really answered your question of time-wise, but it is one extra thing you're going to do. So, but hopefully it's part of your review of your medications. There's other pharmacists on the line. I'm happy for them to maybe have their 2 cents of sort of how they see. Some of our pharmacists probably already doing this really in practice. So, if any of the other pharmacists want to share their experience, I'm happy to hear what they have to say as well. Jen.
Thanks. That's really
Yeah.
helpful just to
Okay,
hear
thanks.
like
Yeah.
the variation in the individual patient too. Yeah.
Yeah.
I think we have a couple more questions. Again.
Thank you.
Hi, thanks, Marissa. That was a great talk. You and I have talked about deprescribing
Yeah.
before as well, and I'm a big advocate for deprescribing, especially in our transplant population. One of our nephro fellows, who's actually going to be our transplant fellow next year, just we recently published a paper in CKD looking at PPI use in kidney transplant patients. We had about 1,800 people and found that about half of them were still on a PPI after the first year of transplant, when immunosuppression is supposed to be at the lowest. And most of those prescribers were nephrologists, and we couldn't find an indication based on diagnostic codes, anyways, for about half of the users. And so our center has kind of developed a policy about, or a guideline to try to deprescribe at the 6-month mark. We're not really following any of the rigorous protocols that you're using, and I was just wondering if there are any for kind of transplant patients, or if we should be using the ones for the dialysis patients in the transplant population.
I think it's a great question. And yes, congratulations on your work. We actually reviewed your paper in Journal Club, and we talked about the same thing at our center, the Big Dallas Transplant Center, saying, we do send them PPIs, and we're going to have to come up with a policy or plan of how we should, taper it off. So I'm not aware of any other data out there. So that's great that you're doing this. I guess my only thought would be is to taper slowly, because a lot of patients get a lot of rebound symptoms. And some of them don't, because they probably didn't need the drug in the first place anyway. So I think it's great that you're doing this. And I think the more you make clinicians aware of this, the more they'll just include it in part of their practice. Or, do you have a Dear Doctor letter? So when they are seeing their family doctor, here's all the medications. We'll take care of these, 5 immunosuppressants, but, the PPI, feel free to start tapering it at this point. Or you could do it in your own transplant clinics. But I agree, I think this is a great place to start.
Yeah, I don't think I've ever had a paper of mine be talked about in a Journal Club before, so that's very flattering. But in some ways, it might be almost easier to do in the transplant population, because there's such a smaller number of transplanters that look after these patients. And so maybe it's easier to come up with an agreed upon protocol. But thank you so much for all your work. And
no worries.
Janice.
You're on mute still. I did that at the beginning.
Sorry. Hi, good morning, everybody. Thank you so much for your amazing presentation. I've actually navigated to your website, looked at your tools, read the case report forms, and as you know, our site is very interested in participating. I wanted to just ask around kind of in your pilot work from a research perspective, not an implementation from kind of a quality improvement perspective, and the fact that this would be research, we would be collecting information, and like I said, having some great buy-in. And in fact, one of our pharmacists is on the call. Just trying to understand from that recruitment slide that you had, and in having, like, if we had this research team, which our research, like our pharmacists would actually be part of the research team, and having such barriers in terms of in Alberta and Alberta Kidney Care South, that consent to approach. So the fact that from a recruitment and screening standpoint, we would have to garner consent to approach as researchers, and then be able to approach, if we got that consent from whoever that person would be, and then consenting them, and then trying to screen them to see if they meet any of the algorithms of the 9 medications that you want to prescribe. So I'd noticed in your one slide that you had a certain amount of patients that were approached, and then it kind of your amount of patients that actually ended up being deprescribed was almost 30%.
A lot less.
Yeah. So, and would you consider, like, so if we had a pharmacist in our program that was willing to assist with being able to do that medication reconciliation and understand whether they might be eligible, were they in your program allowed to obtain that consent to approach, or would that be a conflict of interest, because now they're really part of the research team, they're going to be helping us, and now there's I guess I'm just
I know exactly what you're asking. So I think if you were just implementing this, then you don't need, it's not like an RE, it's not an ethics question, you're just actually implementing sort of usual care of reassessing meds, starting and stopping medications. So that's a different story. But for a study, the pharmacist would not, they're part of the circle of care, they wouldn't be able to consent the patient. They can talk to them about stopping, but you would need a researcher to consent the patient, which is what we did. This, hopefully I can show my results shortly, soon, in the next few months. But so we ran into issues with that because people didn't want to be part of a study, even though like we do this all the time. But we did try to consent everybody, because the point for us is really, it was twofold, not just really looking at implementation, because that's really important, obviously, to share with other centers. But I was also very curious on what patients were taking, like what meds were they on, the number of meds they were on. And so, I think in this last row, we consented 118. We approached 156, I believe. So about 50 of them didn't want to consent, and that's fine. It is what it is. And then so 118, and then 97 out of those 118 were actually on a target medication. I only know this because I'm getting my slides ready for the canceled meeting. So 97 were on target medication, and we deprescribed in 25 of those.
Nice.
So the numbers aren't huge, but to me, it's more important that we're reassessing their medication. We're being mindful of what their medication use, and we also interviewed patients that just completed. We interviewed 13 patients that were part of the study. Some of them did deprescribe, some of them didn't. But their the questionnaire, everything improved. Dialysis care, medication management, deprescribing, all their feelings and thoughts about sort of their care they were getting improved over the 6-month period. And is it because we just spent the extra 5 minutes with them to talk about medication use? And, we monitored maybe a few extra times that we wouldn't have monitored since we stopped a medication as part of a study, but their scores improved, and their thoughts about sort of how medication management and how complicated and it is, not only because they're on so many, but because of the diet, the dialysis care. They don't feel great when they come for dialysis. It was a really big part of it. So I think we have to approach these patients very holistically. So I went off on a bit of a tangent from your question, but I think I did answer your question.
Thanks so much. I look forward to connecting again with you.
Thank you.
Nancy.
Thank you. I'm Nancy Burden. I'm a patient partner. And I come from a qualitative side, so you can imagine where I'm going with this. So one of my, I noticed that your questions were very clear. Did this work or didn't it? Were there opportunities to talk about their experience? Was there an opportunity to share what it's like, particularly depending on where these medications are prescribed, where you actually get a chance to ask questions? Because very often what happens is you'll go in to see your doctor, whether it's your nephrologist or your family doctor or one of your specialists, and they'll say, okay, we're going to put you on X. And I find that, and I'm a retired clinician, so many people just go, okay, sure, yeah, whatever you say. Right. And ironically enough, and I'm speaking from recent experience, when I'm saying to I happen to be a cardiologist, I'm saying to him, but why are you putting me on this? We haven't done any tests to support it. And his response, and you'll love this, you better talk to your nephrologist. They're the ones that you need to discuss this with. And I come back with, well, you know what? I don't know what we're talking about. I'm an OT. I was an OT. I'm not a pharmacist. I don't know this stuff. I'd really prefer that you talk to my nephrologist. Absolutely not. Wasn't going to happen at all.
Interesting.
I got more information from my family doctor than I did from my specialist.
Yeah.
And so when we're talking about experiences, I think that's I'm not sure where you went. I don't know about patient partners on your studies.
Right.
But the key to get that depth that says, yeah, they just keep on adding them, but we don't talk about why, or do we need them more, or can we take something off? At least that's what I've seen and what I've experienced is trying to build that discussion around medication as opposed to just adding to the list, and or even prescribing without any real discussion about that either.
Right. So yeah, thank you for your comments and your questions. So the validation with the patients was actually just the validation of the pamphlet, meaning asking them not really about the deprescribing process, but the information on the actual pamphlet about the medication and deprescribing, and same with the video. But recently, when we did implement our 9 medications, we did 2 things. We did a survey where we did a baseline and a post survey to the patients who were part of the deprescribing study. And we also we've interviewed 13 patients out of the 25. So yeah, so it's not bad, but I shouldn't say that. We've interviewed 9 out of the 25. 4 of them were not in they didn't have deprescribed medication. They were just they were consented to the study, but didn't deprescribe for numerous reasons. They were taking a medication appropriately, they needed it, etc. So we've just started to analyze those results, but our interview was open-ended questions about the process of deprescribing and how they felt, who was who told them information, where did they get more information from. So we asked numerous questions, and it was an open-ended interview. So that's the qualitative piece. So we're still in the process of analyzing it, but I've alluded to a few points that came across just about how everything's so complex and there's so many different people involved in their care. So you raised exactly what some of the things they said.
Yeah, and that's the challenge, right? The number of bodies involved, and everybody has another perspective, and ironically enough, and no surprise, the patient's the last one that's asked for their opinion or their input or to be a part of that discussion.
Yeah.
And the importance of hearing about their experience, even beyond the who and the details. And the reason I think that's so important is it often gives you a different perspective and more depth. So I've been a part of analyzing a number of studies, etc., in terms of data and coding and such. And boy, what we learn from that you think you know. Yeah. And then you go, oh, wait a minute, I didn't know that at all.
Exactly.
So you can see my bias, and I know I'm biased. I totally get it. So
and I think even the people we interviewed were a little bit biased because they were younger, they had higher education, so and we recognize that. But I hear what you're saying. So thank you for your comments.
So we're just coming up to the end of our hour. Thank you again. I think it's been great discussion. And for those on the call, if this tweaks anyone's interest as well in participating in deprescription events and activities, reach out to Marissa, myself, and Selena. And if you have any other topics that might be of interest to the CKD network, always just send us an email. We'd be happy to put it together and reach out. I hope everyone has a good day.
Thanks again.
And thanks.
Thank you.